Dr. Praveer Rai, after obtaining his MBBS degree from Lucknow, performing post-graduation at Kanpur, had joined Varanasi University and completed his DM in 2006. In last 10 years, he has contributed a lot to the academic field. More than 60 publications in the internationally peered journals. And in any national or international meetings in India, he is the key speaker in those meetings. So today we are going to hear from Dr. Praveer Rai about the metabolic syndrome and non-alcoholic fatty liver disease.
Firstly, I would like to thank Dr. Hemant, Dr. Monica for providing me this wonderful opportunity. It's really a pleasure speaking in front of my teachers, Dr. Jain, Dr. Dixit. It's only because of these teachers that we have learned whatever gastroenterology we could. So I'll straight away come to the topic. So it's non-alcoholic fatty liver disease and how it correlates with metabolic syndrome. So you have to understand this term of non-alcoholic fatty liver disease. It means that there is a fat accumulation in the liver associated with insulin resistance. So two things are important. One, there has to be fat in the liver, that is steatosis, and then there has to be insulin resistance. And the definition, it is defined by presence of fat in more than 5% of hepatocytes on histological analysis. That means you need a biopsy to confirm that, or by a proton density fat fraction, which is a technique to determine the liver fat. Or you can do an MR spectroscopy to determine the quantity of fat. With this, if you want to say that the patient has got primary NAFLD, that is non-alcoholic fatty liver disease, you have to exclude secondary causes. I'll come to what the secondary causes are, and alcohol abuse. So it's non-alcoholic, so you ought to have, the patient is not taking alcohol, and the cutoff alcohol, which has been recently determined by EASL, European Association for the Study of Liver Disease 2016. So alcohol intake less than 30 grams in male and less than 20 grams in female is considered to be non-alcoholic. So what they have mentioned in the guidelines, surprisingly, that if you take less than 30 grams of alcohol, it's possibly protective compared to those who don't take alcohol. Okay, so what is NASH? So non-alcoholic steatohepatitis means it's a part of non-alcoholic fatty liver disease. Steatohepatitis means that along with steatosis, that is fat, you have inflammation also, and this inflammation is because of the liver cell injury. So the term steatohepatitis, it's usually a diagnosis by biopsy. So without biopsy, you cannot make a definite diagnosis of steatohepatitis. However, you have other markers to suggest that the patient is having steatohepatitis rather than only steatosis. So why it's important to differentiate between the steatosis or just the fatty liver and steatohepatitis, that is NASH, I'll come to that. So if you see the prevalence of non-alcoholic fatty liver, the prevalence is around 16% in normal population. This is again a study from the West. Age less than 20, it is 20%, greater than 60, 40%. In diabetics, the prevalence increases to the tune of 43 to 60%. And in obese, again, who undergo bariatric surgery, obviously here the BMI is more than 35, it's found in 91%. And hyperlipidemic patients, again, the prevalence of NAFLD is very high to the tune of 90%. So what I want to highlight with this is that diabetes, obesity, hyperlipidemia are closely correlated with NAFLD, that is non-alcoholic fatty liver disease. So again, this is a slide again of prevalence. The important thing to note in this particular slide is, in the East, the prevalence is to the tune of 15 to 18%, while in the West, it is high. This is 27 to 35%. And if you see the obese, moderately obese patient, the prevalence is very high, 90 to 95%. If you see the overall patient of non-alcoholic fatty liver disease, only a proportion of it have steatohepatitis. It's around 10 to 20%. So a correlation between NFLD and metabolic syndrome. So NFLD is considered to be a hepatic manifestation of the metabolic syndrome. And it's related with cardiometabolic risk factors as well. About 90% of the patient of NFLD have at least one feature of the metabolic syndrome. The definition has already been defined multiple times earlier. And 33% of the patient may have all the features of metabolic syndrome. In patients with metabolic syndrome, the prevalence of NFLD increases by around 4 to 10 times. In type 2 diabetes, again, the prevalence of NFLD is high. It is around 30 to 55%. And the prevalence again increases in patients with hyperlipidemia. This is a slide which shows the pathogenesis of NASH, that is non-alcoholic steatohepatitis. I'm not going into the detail, but the bottom line of this slide is insulin resistance. So insulin resistance is the common link between metabolic syndrome and the NASH. So this is the basic reason of both the disease. So again, this insulin resistance and the presence of excess of adipose tissue, adiponectins come into play, that is inflammatory mediators, increased amount of fatty acids, increased deposition of triglycerides, and that's how the steatosis comes into play. So the common pathogenic link between the NASH and the metabolic syndrome is the insulin resistance. So this slide clearly tells you what I mean is, if you see this insulin resistance in the center, it leads to NASH, it leads to metabolic syndrome, and metabolic syndrome leads to insulin resistance further, NASH leads to insulin resistance. So these are a part of the same spectrum. In diabetes, so message what I want to give in this particular slide is, in patients with NFLD, look for diabetes. So a lot of physicians see NFLD, fatty liver, a lot of these patients are referred to as gastroenterologists. So it's mandatory to test for diabetes as well. I'll be coming to the complete list of evaluation that is needed in patients with NFLD. But here the crux of this slide is, in patients with NFLD, look for diabetes. In patients with diabetes, look for liver disease, non-alcoholic fatty liver disease. So this is the spectrum of NFLD. Normal, then we have steatosis. Steatosis means just the deposition of fat. Steatohepatitis, it means there is ballooning degeneration, there is lobular inflammation, and again this leads to cirrhosis, decompensation, and hepatocellular carcinoma, which you want to prevent. So this is the spectrum again, what I was highlighting. In non-alcoholic fatty liver, you just have steatosis, that is, there is just fat which may be benign or silent, along with that mild inflammation at best. But if you say NASH, non-alcoholic steatohepatitis, then that is a troublesome condition where you can have fibrosis from F1, F2, F3 fibrosis, F4 fibrosis, and later on there can be development of hepatocellular carcinoma. So NASH is not a benign condition, need to be taken care of. So we'll come to how it can be managed. So if you see the natural history of NFLD, around 70 to 75% of the patient will just have fatty liver. So majority will have just fatty liver, and majority of the studies say that these fatty liver usually do not progress. So it means it's just steatosis. They do not progress, and there may not be increased risk of death. So this is steatosis. However, if we say NASH, which happens in around 20 to 20% of the patient with NFLD, this is associated with an increased risk of death, which is primarily cardiovascular, malignancy related, or liver related because of decompensation or hepatocellular carcinoma. And NASH with fibrosis, so if you have fibrosis established either on fibroscan or a liver biopsy, it portends a grim prognosis. So if we see the natural history, NASH can progress in around 11% of the patient over a period of 15 years to cirrhosis. And this, over a period of further 6.5 years, 7% of these patients will progress to hepatocellular carcinoma. So it's very important to prevent this, and cirrhotics over a period of 10 years may have a decompensation in 20 to 45% of the patients. So cryptogenic cirrhosis, so normally when we see a patient with cirrhosis, we evaluate for etiology, hepatitis B, hepatitis C, autoimmune hemochromatosis, Wilson's disease, and if we don't find an etiology, we label them as cryptogenic cirrhosis. Some of these patients are burned out NASH, and this particular sentence I've taken from a review which said, I didn't get the reference for that it is around 80% of these patients have a burned out NASH. So as I've been talking of that this is not a benign condition, so I'm just putting up literature to suggest that if we compare to the general population over a period of, over a period of more than 7 years study, the patients with NFLD had decreased survival. Again, another study which showed that the patient with just steatosis may have a survival similar to that of a general population, but NASH is clearly the culprit, and the survival in patient with NASH is definitely less. Again, as has been pointed out earlier, metabolic syndrome, NASH leads to cardiovascular disease, and you need to evaluate for these as well. So I think this part, NFLD management, to me is very, very crucial, and we need to understand what we can do in this particular setting. So one is screen all patients with persistently abnormal liver enzymes for NFLD. That means you have any patients with SGOTPT raised, refer to us just for enzyme elevation. So NFLD is one of the cause, and we need complete evaluation of NFLD in this setting. Second is patient with obesity, metabolic syndrome, all need to be evaluated for NFLD. And all individuals with steatosis should be screened for metabolic syndrome. So as I said, one leads to another. Again, the alcohol intake and the metabolic factors interact. So that again needs to be seen. So if you see the diagnostic evaluation, we need to do a lot of investigation in patients with NFLD, and these include, as I said, the components of metabolic syndrome. Besides that, the serum bilirubin, all liver enzymes, albumin. You need to screen for hepatitis B, hepatitis C, autoimmune profile, fasting blood sugar, obviously for diabetes. Then you need to know the BMI of the patient, again a part of the metabolic syndrome. Imaging, ultrasound abdomen is the first initial imaging that needs to be done in these patients. And if you have a strong suspicion of NFLD, non-alcoholic fatty liver, ultrasound is not giving you a fatty liver, you may even do a CT scan in these settings. Again, as I mentioned earlier, another etiologies of chronic liver disease needs to be ruled out, that is hemochromatosis, Wilson's disease, alpha-1 antitrypsin. So we have evaluation, we can do blood investigations to confirm all these. So as far as the imaging is concerned, ultrasound is the preferred first-line diagnostic procedure for NFLD. It gives other diagnostic information as well. So what do we see on ultrasound? You see a bright liver. So those of you who have done a transabdominal ultrasound or doing endoscopic ultrasound, we know that in a patient with fatty liver, you see a bright liver compared to what we normally see, or more brighter compared to spleen of the kidney. So characteristic features include diffuse hyperechoic ecotexture, increased liver ecotexture compared to the kidney, vascular blurring, non-visualization of the echogenic wall of the portal vein branches. So what I mean by this is, if you see the grading of steatosis, grade 1 is simple increased echogenicity, grade 2 is normally the walls of the portal vein is hyperechoic. So when you don't see this hyperechoic walls of the portal vein, this is grade 2 of steatosis. Grade 3 is echogenic liver obscuring the outline of the diaphragm. You can see a bright diaphragm in the second and the first, but not in the fourth. So what is a transient elastography, also known as fibroscan? It is a non-invasive method of assessing the liver fibrosis. So what you have to understand very clearly with elastography, the intent is not to just pick up fat, but to see the fibrosis. So it is a measure of the stiffness of the liver. So it evaluates the stiffness of the liver, how hard the liver is, and what you assume here is as the score increases or as the hardness increases, the score of the fibroscan also increases. If you see this, less than 7 may be normal, up to 9.5 is F2, up to 11.5 is F3, and more than this is cirrhosis or F4. So these values becomes very important, a very easily available tool to determine the liver fibrosis in the liver. So there are another tools for determining the diagnosis of NFLD. So these includes the liver enzyme, that is gamma glutamine transminase. However, it's not reliable. Ultrasound, as I mentioned, is cheap, readily available. The problem is it cannot distinguish between the steatosis and fibrosis. That is an important distinction that needs to be made because it determines the outcome. Then, as I mentioned, CT scan. So CT scan may be on ultrasound may be unreliable in patients who are morbidly obese. You can't see the liver because of the lot of fat. So there you can do a CT scan to make a diagnosis of NFLD. And to quantify the liver fat, the investigation is again MR, and it quantifies the liver fat most accurately. However, the gold standard is liver biopsy. The problem is, even in our center, we rarely do liver biopsy. The indications of liver biopsy I will come to, but for all practical purposes, I would say that it's very rarely that you need liver biopsy in patients with NFLD. So as I mentioned, the limitation of these non-invasive blood tests which I have tested and other imaging are, these cannot distinguish between non-alcoholic steatohepatitis and fatty liver. So this distinction cannot be done based on the imaging and the blood tests that I have mentioned. So there are some tests which are suggested for NASH. Again, we don't do all of these routinely in our center except for fibroscan, which determines fibrosis. So here it has been shown that transit elastography, MR elastography, you can see the sensitivity of elastography again may not be very great, it's 70%. And MR elastography, the sensitivity is only 33%, which is quite low. So very, very difficult to make a definite diagnosis of NASH. What you commonly do is you see steatosis with raised enzymes, you assume that the patient is having non-alcoholic steatohepatitis rather than steatosis alone. So these are another non-invasive markers. Someone was asking about some biomarkers. So these biomarkers are available for patients with NASH. Besides biomarkers, we have some fibrosis scores also. So I'm not going into the detail. One is AST platelet ratio, another is NFLD fibrosis score, which includes around 4 or 5 variables, including weight, age, BMI. Then BART score is again includes BMI and AST-ALT ratio and diabetes, and other scores like HIPAA score, fibroscan. So these are the measures, these are the tools that you can use to diagnose liver fibrosis in patients with NFLD. And what do the guidelines say? This is again EASL guidelines, which say that whenever imaging tools are not available or feasible, the serum biomarkers, that is these scores, are an acceptable alternative for the diagnosis of steatosis. So coming to the management algorithm, so if you have a persistent elevation of the liver enzymes, exclude other liver disease, you see the risk factors, if they are present, suggest diet and exercise and treat metabolic factors. If the patient has signs of cirrhosis, that is advanced liver disease, F2, F3 fibrosis, you can go ahead and do a liver biopsy primarily for prognostication rather than anything else. And if the patient does not respond even after 6 months of diet exercise, then you can go ahead and do a liver biopsy. So liver biopsy, as I mentioned, primarily is done to confirm, one, the diagnosis of NASH, second, to stage the disease, third, to rule out other diseases. So sometimes other disease, autoimmune hepatitis, the diagnosis can only be made on liver biopsy and by no blood investigations, and determine the need and the urgency of the aggressive therapy if needed. So liver biopsy, again, these are the indications where you should be doing a liver biopsy. Other, for all practical purposes, liver biopsy in NFLD is not needed. So what do you do? Simple steatosis, good prognosis, nothing needs to be done. If you have a NASH, treat associated conditions. How do you treat is important, which I'll go to straight away. One, there is no drug which is FDA approved. One. The important point which has been highlighted earlier, but I would like to highlight it further, is the lifestyle modifications. Very easy to say, but very difficult to follow. But what needs to be done, we need to be aware of that. So if you see, in overweight or obese NFLD patients, 7 to 10% weight loss is the target. So that is very important. From the baseline, whatever your weight is, the target is 10% reduction of the weight. Dietary recommendation, energy restriction, that is the caloric restriction. One, the type of calorie, type of macro, micronutrient, again, is not that important. Energy restriction and stopping of processed food, beverages with high fructose. Again, the type of exercise becomes very important, both aerobic exercise as well as resistance training. Resistance training is you are lifting dumbbells or doing bodybuilding. This is again a resistance training. Both are considered to be equally effective. And you should comply with the one which you can follow for long. So if you see the caloric restriction, how much caloric restriction? Around 600 calories less than the daily requirement. So you ought to know the daily requirement of your weight, your BMI, 600 calories less than that. And this amounts to what? What are you intending? You are intending around a 10% reduction in weight. This I told you is the target, 10% reduction in the weight. By this you will achieve decreased steatosis, decreased ballooning, decreased inflammation. That is, even NASH will be reversed. Again, how much to lose? Again, becomes very important. If you starve yourself, you can reduce weight dramatically. But the recommended is around 1 kg per week. Again, very, very important. There's increased risk of, again, gallbladder stone formation if you do a very rapid reduction in the weight. So 1 kg per week is permissible. And avoid saturated fats, simple carbohydrate and sweetened drinks. Physical activity, again, you have to cut down your time of sitting idly. So that has to be reduced. How much exercise? So very common question that the patient asks that I'm exercising for the last 6 months, I haven't reduced my weight. So the problem is you have to figure out what is the type of the exercise and what is the type of the diet patient is. So I can tell you the recommended time of exercise is around 30 to 45 minutes per day, at least 5 times a week. Very, very important. So if you are doing exercise less than this, you're not going to get benefit. So you're not going to lose weight, you're not going to improve your NASH. But if you do this, there is improvement in the liver enzymes and there is reduced liver fat. So again, as I mentioned, between the resistance training and the aerobic exercise, both are equal. So in the mobile also you can fix the number of steps. I think every mobile has that. What the guidelines recommend is around 10,000 steps. The steps that you walk, 10,000 steps per day is the minimum recommendation. So if you are reducing more than 3% of the weight, you decrease steatosis to around 35 to 100%. If you reduce 5% of weight, you decrease the ballooning, that is the inflammation, lobular inflammation. If you decrease more than 7%, there is a NASH resolution. Mind you, this is 64 to 90% NASH resolution. Weight loss more than 10%, even regression in fibrosis. So this is just by diet and exercise that you are decreasing the fibrosis score and decreasing the fat content of the liver. So again, very, very important. So as far as drug, because most of the patients are not all, they are not all keen in doing vigorous exercise or sticking to 30 to 45 minutes, they want a drug. But unfortunately, there is no good approved drug for this. I'll come to what drugs we have and what are the indications. So indications of drug are 1, NASH with stage 2 fibrosis. So if you do a fibro scan, see the value more than 9.5, up to 11, more than 11.5, it has F3 fibrosis at least. These patients need treatment. Again, if you have a less severe disease, maybe F2 or F1, but with high risk of progression, that is association with metabolic syndrome or high ALT, persistently high ALT, these patients again need drugs. So what drug? Two drugs which in trials have shown some benefit are pioglitazone and vitamin E. So you can use either or both. However, the problem here is the optimal duration again is not established, and the stopping rule here is clear. If the ALT is increased at baseline but does not drop after 6 months, you should stop the drug because the drug is not going to work. So if you see this, this is an NEJM trial, PIVINS trial, that is pioglitazone, vitamin E for non-alcoholic steatohepatitis. This shows that the resolution of NASH does happen with vitamin E and pioglitazone. So dose of pioglitazone was 30 milligram, dose of vitamin E was 800 milligram, not 400 milligram compared to placebo. So some resolution of NASH occurred with pioglitazone and vitamin E. However, there was no improvement in the fibrosis score. So fibrosis didn't improve. It was only the NASH which improved. So two drugs which you can prescribe. So pioglitazone recommended for patients with aggressive NASH who have failed lifestyle interventions. So lifestyle interventions again comes first. It reduces the hepatocellular injury and fibrosis to some extent. However, you have to be concerned about one of the important side effects, though which is rare, is congestive cardiac failure that can happen with pioglitazone. Vitamin E again reserved for selected patients with pre-cirrhotic NASH who have failed lifestyle interventions. Again, a word about the bariatric surgery, when to get it done. Treatment if obesity, for obesity, BMI is greater than 40 or between 30 to 40, 35 to 40 with other significant disease. Bariatric surgery, if you get it done, reduces steatosis, reduces steatohepatitis and fibrosis. So we have some new drugs, not some, we have many new drugs in the pipeline. I'm not going into the detail because that will be another complete lecture. So just to name a few, these are elafibrinator, elafibranor and obeticholic acid. These are two drugs which have undergone phase 3 trials and have suggested an improvement in steatosis and NASH. Again, if you have a patient with diabetes, the first line drug should be metformin. The metformin, if you have a patient with NAFLD associated, the reason why it should be used is that it helps in weight loss, it reduces the risk of any diabetes related endpoint and reduces the hepatocellular carcinoma risk. So there's another study which showed that the risk of HCC, it's decreased, hepatocellular carcinoma is decreased when you use metformin. Another drug that you can use in diabetics with NAFLD is pioglitazone, as I've showed. Third line drugs may be GLP analogs. And in hypertension, so if you have NAFLD associated with hypertension, the drugs to choose will be telmisartan and valsartan. These interact at the pathogenetic level and helps to increase the insulin sensitivity, decrease NASH activity score and fibrosis. And if it is dyslipidemia, you use statins. Statins are safe in patients with liver disease and they improve liver enzymes and cardiovascular outcomes in patients with deranged LFT. So to conclude, NAFLD and NASH is a common disorder. It's a hepatic phase of the metabolic syndrome. Its commonest cause of the cryptogenic liver cirrhosis, what you say as burned out NASH. Cardiovascular disease, malignancy are the major complications that can happen. Lifestyle modification is the cornerstone of therapy, that is diet and exercise. New drugs are being developed as pathogenesis is better understood and prospective for effective pharmacotherapy are still bright. Thank you.